I welcome all the delegates and the faculty and the organizing team for this wonderful international webinar endorsed by uh, American College of Gastroenterology. I am Dr. K. Chandrasekhar, your American College of Gastroenterology Governor, India region. I represent as a member of webinar subcommittee of American College of Gastroenterology. And I bring warm greetings from the local Dr. MGR, Tamil Nadu Dr. MGR Medical University as the honorary distinct professor. And I bring warm greetings from my institution, that is Med India Hospital and Academy. And this introduction. So this short video presentation tell you that we had earlier 3 series of international webinar that attracted over 19,000 delegates from all over the world. That really inspired us. And even during COVID-19, also we did the webinar. And this inspired us to go ahead with the 4th series of international webinar, that too with the encouragement from the American College of Gastroenterology and our ambassadors. We gave the tagline, name the topic, the world experts are here. I must be thankful to them. And this is the new Endo GE webinar series that created a news actually, NEWS, new Endo GE webinar series. And I'm glad to inform you that these webinar series were inaugurated by none other than Professor Dr. Jonathan Lighton, President of American College of Gastroenterology. And one of the series we witnessed the presence of as faculty of Professor Dr. Barry Marshall, the Nobel laureate. He's a discoverer of Helicobacter pylori, as you know, and which revolutionized the management of peptic ulcer and stomach cancer. And he gave the lecture on the journey of discovery of Helicobacter pylori and further. And this webinar has been very successful with the cooperation coordination from my team, Dr. Gokul, Dr. Satya, Dr. Yogesh, Dr. Prasad, and Dr. Trinyana Sambandam. And now presently we have planned and scheduled 12 webinars starting from April 25 to March 26. Every month, one webinar on very interesting topic. And we have very eminent international faculty and national faculty. You name who is who in gastroenterology in India and international arena, who are predominantly from USA. And we had the benefit of having their wisdom, experience, and the knowledge and their expertise for our webinar. And we did have all the other stalwarts from India and rest of world as moderator, Dr. Ravi Roy, starting from Nalini Gouda and Dr. Jasmohan Bajaj and Dr. Anil Arora, Mahesh Goenka, and so on, and panelists also from everybody. And what we did is started in April type 2 diabetes and GI tract, systemic hypertension and portal hypertension, and dyslipidemia and fat and liver, pharmacotherapy of obesity, endoscopy and surgical management of obesity, doctor and law, doctor and ethics, doctor and research grants, and various other topics, research methodology 1 and 2. And now currently the master checkup and precancerous lesions and GI tract. And next month we are going to have 2021st, 22nd, we are going to have the live workshop and conference. And March, but last but not the least, there is going to be a debate on endoscopy versus surgical management in gray areas in gastroenterology, physician perspective and surgeon's perspective. Don't miss it on March 12th. And currently this webinar has been successful. Tamil Nadu Medical Council has given the credit hours of 1 hour. And today we are going to have two important topics. Master health checkup in gastroenterology, how relevant it is, and pre-cancer lesion in gastroenterology, screening methodology and management. Now is my pleasant duty and honor to introduce my faculty here. The first speaker is Professor Dr. L. Taimanavan. He has been a professor in HOD Department of Gastroenterology, Madurai Medical College, Madurai, and he's our consultant gastroenterologist in our own institute. He focuses on abdominal tuberculosis, IBD, and biliary and pancreatic endotherapy. He is the recipient of Best Teacher Award from the Tamil Nadu Dr. MGR Medical University. He has delivered several prestigious orations, published in peer-reviewed journal, and authored several book chapters. This topic will be moderated by Professor Dr. Bruce Cash. He is the medical director and functional bowel center, Baylor, Scott and White at Baylor University Medical Center, USA. Is a professor, Texas A&M Medical School, USA, member of Educational Affairs Committee, and he is the recipient of William Carey Award for his exceptional leadership, which I could see in during the dry run also. He has been in the Rome Foundation Fellowship Award in 2020, and he has got a tremendous H index 86. We welcome you, Dr. Brooks, and Dr. Kayesh and Dr. Tayu. The next speaker is my younger colleague who is also doing a great work in our institute. Dr. S. Satyamurthy is a consultant gastroenterologist of Medindia Hospital, Chennai. He specializes in gastroenteral motility disorder, hepatobiliary pancreatic disorder. Now currently in IBD, and uh, his focus is on third space also now, US, GMR, and ESD, and third space endoscopy. And he has authored several publications. This will be handled by moderated by Professor Dr. Sid Gross. He is a professor of medicine at U. Grossman School of Medicine, clinical chief and division of gastroenterology, Langham Health, USA, Board of Trustees, American College of Gastroenterology. I am very fortunate that whomever I invited from ACG, Board of Trustees, Board of Governors, they have been part of this webinar team. And Dr. Gross, research interests include gastrointestinal malignancies, the right candidate to discuss about the pre-cancerous lesion screening methodology. He focuses on preventive, diagnosing, and treating GI cancer. He has got tremendous publication over 100. Now we have very enthusiastic, very eminent panelists, and I always regard him as the emerging power in women in gastroenterology. Dr. Sivangi Kotari, the Associate Professor of Medicine and Division of Gastroenterology. Actually, whenever we need any help to conduct any academic program in India, we lean on Dr. Sivangi. So I must be thankful. I must express my gratitude and thanks to Dr. Sivangi. She is representing from the Strong Memorial Hospital, Rochester, USA. We have two younger colleagues from India, Shaheen Nazir from Sri Kashmir Institute of Medical Sciences, Srinagar, Kashmir, and Dr. Jayant Ghosh is the consultant gastroenterology department of gastroenterology, Orchid Medical Center, Ranchi, Jharkhand. So I welcome all the faculty to this. This webinar has become very popular all over the world because of the ambassadors we have from each one representing from every state of India, and we do have international ambassador representing from USA, Malaysia, Nepal, Bangladesh, Nigeria, UAE, and Australia, Sri Lanka, and so on. So we have the benefit of exploiting the digital platform to conduct these webinars all over the world. With this, now I call upon Dr. Cash to introduce the topic, and I invite the first speaker, Dr. Tayu, to give a lecture for lecture on the master health checkup in gastroenterology, how relevant. So the format is like that, back to back. We have both the lectures and followed by the moderators and panelists will take up the challenging questions already from our registered delegates and expert comment from them. So with this, I call upon Dr. Cash to start the proceeding.
Thank you very much. It's a tremendous honor to be asked to participate, and I just want to extend my thank you for that invitation. It's a real thrill for me. So it's my absolute pleasure to introduce Dr. Thayu. He's going to be presenting a lecture entitled Master Health Checkup in Gastroenterology, and I'm sure we're all very excited to hear his lecture. And I think this is going to be a very intriguing next 28 minutes, and then we'll have a very robust question and answer session.
Thank you. Thank you, Professor Cash. Am I audible and visible?
You are audible, Dr. Ayu, and slides are very nice, colorful.
Okay. Yeah.
Cash is listening to you. Okay. All of us are very eager to listen to this very important topic. Thank you.
Thank you. Most distinguished Professor Cash, who has volunteered to chair my session. I at the outset thank Dr. T.S. Chandrasekhar, Chairman, Mid India Hospitals, and the Governor of the Indian region of the American College of Gastroenterology to have thought of a very topic called comprehensive health checkup and its relevance to gastroenterology. Now, before I actually start the topic, I would like to talk about 3 real-world cases. One was a 70-year-old man. He's a doctor. He's been having steatotic liver disease, liver functions normal, and has been on health checkup every year. And this year, he developed an SOL in the liver. When he came for investigations, he was declared HCV positive. The second is a software professional in New Zealand and of Indian origin. He used to have a hemoglobin of about 10.9 to 11.6, and his stool occult blood was positive. Investigations revealed a small tumor in the small intestine. He was diagnosed as leiomyoma and is on treatment. Third is an elderly gentleman who does his health checkup. And this year, he suddenly discovered that the ultrasound revealed a diverticulum in the urinary bladder with a small 5 millimeter polyp. And investigations revealed he had uroepithelial carcinoma. These I just want you to remember, and we will remember these cases at the end of 30 minutes and see what relevance it is. Now, Master Health Checkup has had its roots way back 3000 BC, and even Hippocrates has emphasized lifestyle, balance, and early detection of diseases, and it is therefore pretty old. But the periodic health exams was done in 1900s when the life insurance companies did their health checks, and probably because they wanted to actually look at how much to get the premiums of pre-existing diseases. Next slide. But actually, the WHO promoted early detection of non-communicable diseases, screening for hypertension, diabetes, and cancers in the early 70s and 80s because of the epidemic of non-communicable diseases like diabetes, hypertension, dyslipidemias. But it was actually the corporate hospitals that introduced the mass health checkup, driven by the lifestyle diseases, demand for the middle class, and access to diagnostics. And therefore, today we have a comprehensive package that includes blood tests, abdominal ultrasound, cancer screenings, cardiac tests, and stress tests, and it is going to be now tech-driven and data-based. So you have a timeline which says that this in the 2000s, we'll have tech-enabled population-based MHCs, and let us see what the problems, how do you go about screening the whole population. Now, if you have information of a projection of 15 million people born between 2008 and 2017, who are going to be predominantly in Southeast Asia, especially India and China, and look at that mind-boggling figure of 16,57,670 people who may develop gastric cancer. And if you can actually treat them for H. pylori, you can bring down the disease burden by about 75%. Now, if you've got this kind of information, you need to have screening. And screening is nothing but a comprehensive health check. So now, in the next 28-30 minutes, our agenda will be identifying disease patterns, identifying colorectal cancer, upper gastrointestinal cancer, liver diseases, screening guidelines, outcomes and economics. Is it possible to get the entire population screened? Emerging tools and the relevance of AI. And the challenges are about over-diagnosis, adherence to protocol, and access of the people to MHC. Now, this was a study done in Apollo Hospital. It said, significance of preventive health checkups in enhancing well-being. Is it true? Now, they have surmised that preventive health checkups aim early detection of health risks. Growing lifestyle and environmental risks make PHC or preventive health checkup crucial. And the review evaluates the PHC's impact on the well-being and early intervention. Now, if you looked at their introduction, they said, amongst all the studies that they had seen, there is lowering of all-cause mortality by 45%, And these health checks have been endorsed by CDC and other global health bodies, supports early treatment and lifestyle modification, and empowers the individuals to make their own informed health decisions depending upon what the health check shows. And therefore, preventive health checkup identifies risks, symptoms before actually they manifest as disease. Now, let's read the last 4 sentences. We look at the pros, cons, and the future directions a little later. Preventive health checkup enhances early detection of diseases, allowing timely interventions. Regular preventive health checkup helps in better recognition and management of chronic diseases. Lifestyle modifications can be guided by insights gained from the preventive health checkup. But what is most important is the targeted preventive health checkup initiatives could have efficient use of healthcare resources while minimizing the risk associated with overdiagnosis and misdiagnosis. Now, the healthcare resources is the most important thing in any country. If somebody is rich enough, he has access. But what happens to the general population? Now, the key highlights, of course, was targeted PHC ensures efficient use of healthcare resources, and this will become the mainstay of any health checkup. So now, if you need to have something that needs to be organized, for young adults, you have a physical check and the battery of blood tests, and perhaps aim a little at sexually transmitted diseases and mental health. For the same in the middle class between 40 to 60, you have the same group of diseases, and perhaps add cancer screening and the cardiometabolic syndrome that needs to be identified. For older adults, the same, plus perhaps to make their lifestyle better, maybe some kind of assistance for vision and hearing apart from what is done routinely. But for certain people with a family history, let's say essential hypercholesterolemia or breast cancer or colon cancer, there will have to be individualized recommendations. So now what are the components? The components are physical examination, laboratory tests, which are routine. I'll come to that a little later. There'll be screenings for cancer, cardiometabolic syndrome. There'll be a detailed health history and lifestyle assessment. There will be counseling because there are people who need to be counseled even before and after the master health checkup. Specialized screening for those few who have identified diseases that needs to be detected. And of course, nutrigenomics, personalized exercise plans, and stress management techniques also will become a part of master health checkup. What are the diseases detected? Essentially cardiovascular, hypertension, dyslipidemia, atherosclerotic heart disease, type 2 diabetes mellitus. Amongst the cancers, you have breast cancer, cervical cancer, colon cancer, prostate cancer, skin cancer, and lung cancer. And as a result of the health checkup that also identifies kidney diseases, liver disease, especially steatotic liver disease, thyroid disorders, osteoporosis, and sexually transmitted infections. While it is easy for us to identify that there are a lot of advantages, that it is cost effective, gives peace of mind to those people who have got normal blood tests, we must remember that there are certain disadvantages as well. What happens if I'm suddenly said, I've got diabetes or I've got a tendency to develop cancer? It produces potential anxiety, especially if you have false positives, and the cost and the time consuming effort that is gone to. Now, let us just, for example, identify whether false positive really is a problem. Look at the study. Prostate cancer, breast cancer, thyroid, and lung has a range of estimates of overdiagnosis of between 40 to 50%. So it is not just that there is an overdiagnosis, it is a reality. And therefore, these kind of tests that come in the mass agriculture, these people need to be counseled before and after to tell them that if you did have an abnormal test, this needs to be verified. And if it's false positive, you're only lucky that you have detected it early. Now let's look at a small study that was done in a peripheral type 2 stage 2 city near Tiruchirappalli in my state. There was 436 participants. Only 130 had mass health checkup ever. In a web report, 75% of Indians get tested done only if they are ill. And in other countries, at least MHC is done once in 2 years. So why is it that MHC is not preferred across the world? It is because, at least as far as this study was concerned, there were people who said, I'm healthy, why should I do it? Tests are expensive and unreliable. There were people who were not aware at all. There are people who said, I'm afraid of disease discovery. Tests are not available in my area. And some people even said it's a method to make money. And therefore, the disparity is that if you got coming from a high income society, or if you're rich enough, or you come from an area where you have access to availability, scope, frequency, quality of care, cultural factors, they do not make an impact because you're rich enough to hold it. But for low and middle income, where there is poverty, reaching, especially availability, accessibility, frequency, is a problem. And therefore, with the limited resources, financial constraints, geographical barriers, culture and social factors, and health system challenges, especially in a country where you have a weakness of the personnel, and the intermeeting pandemics, especially when Corona took place in these 2 years, you will have disruption of the mass health checkup. All these will form disparities of care. But of course, you need to find solutions. And the solution is the hexagon that is right on the top, strengthening the healthcare system. While you can strengthen it, it is important that you identify those people who need the checkup, and that is one of the methods by which we have access to people even in the villages. So now let us just identify, and having seen the problems related to healthcare, let us see the usefulness of mass health checkup in non-communicable diseases detection. Is this true? Look at the conclusion. Based on the results of the study, it is evident that a number of non-communicable diseases were newly identified by the health checkup. So that means people who are completely asymptomatic, there was a significant number of people who were identified as having NCDs. This was done in SRM General Hospital. The number of people was, of course, limited. 337 participants, 156 and 181 males and females. Age was between 36 to 59. Education was 1/3 were graduates, homemakers, and actually 50% were referred by doctors themselves for the checkup. Now, you looked at the 337 participants. The study detected 12.3% type 2 diabetes, 37.7% of the pre-diabetic stage. There was anemia, dyslipidemia, hypothyroidism, steatotic liver disease, and renal disorders, especially amongst females above the age of 35. Females had more anemia, hypocalcemia, dyslipidemia, and hypothyroidism, and age 35 had higher diabetes and dyslipidemia. Dyslipidemia was found even when the sugar levels were normal, indicating that they need not be diabetics, but they have, especially in India, we have hypertriglyceridemia as a big problem because of our lifestyle as well as genes. So they discussed and said findings aligned with previous Indian studies. There was high rates of anemia, pre-diabetes, hypothyroidism. Age and gender were strongly linked to non-communicable diseases, and MSC can identify silent diseases early. Mixed global evidence, but local findings support the usefulness of PHC, and the mass health checkup enables early interventions to prevent complications. So they decided that high prevalence of new cases in apparently healthy individuals underscores the need for routine health checkup, which is a mass health checkup. But then the study had only 300 odd people. So if you have a larger study, look at the fatty liver, 65% had steatotic liver disease. There was early atherosclerosis in 46%, hypertension in 26%, vitamin D deficiency was detected, sleep apnea was seen in 24%, and there was even depression in 6%. So the high prevalence rate of early stage disorders to detect them is important. Metabolic and cardiovascular risks are common. Vitamin D deficiency is widespread across genders. Renal, thyroid, and liver issues are often asymptomatic, and therefore a mass checkup is very useful in detecting hidden conditions early. Now, we have identified that non-communicable diseases like diabetes, hypertension, dyslipidemia, atherosclerotic heart disease are definitely detected in asymptomatic individuals. Let us look at the usefulness of health-based checkups in identifying metabolism-associated steatotic liver disease, for which the MSCs were initially intended. Here, this study was actually done in Japan. They had the normal test, but in addition to the normal test, using that information, can we identify who are the subset of people, even amongst the fatty liver, who needs to have a greater surveillance program? So this was a cross-sector study among 627 Japanese university staff. This was done under the Occupational Health Safety Act of Japan. And the standard definitions were the same. MASLD was diagnosed as steatosis plus one of the metabolic disorders. Overweight, glucose, and triglycerides were all internationally known definitions. And we had two extra calculations. One is called FLI, which is called the fatty liver index. There was a hepatic steatotic index, which we could calculate using the computer. Now, is this important than, let's say, the AST and ALT, which we have routines? Now, if you had an FLI, they divided it into less than 30, between 30 and 60, and above 60. If you find that if you're less than 30, you had perhaps a normal liver and perhaps not very great to be worried about. But if you are between 30 and 60, you are the person who is likely to run the risk of developing not only liver disease, like non-alcoholic steatohepatitis, cirrhosis liver, and hepatocellular carcinoma, but also 4 to 8 times risk of developing thyroid cancer, breast cancer, colon cancer, stomach cancer, and esophageal cancer. And we'll identify that FLI get at the cutoff rate in this particular study was just 37. If above 37, if you can identify steatotic liver disease and identify that these are the group of people who need to be kept on greater surveillance, that gives you a better index than simply AST. We will go to what the study really means. MASLD prevalence was 28%, 38 males and 18% females. You find only 2% had NAFLD alone, which is lean NASH. ALT was very strongly associated with identifying MASLD, and odds increase when the ALT increase in both sexes. The cutoff, as you said, was about 30. Now, if Dr. Sareen in India says that the predetermined level should be 20, can you imagine that we thought all the AST and ALT, 30 was the cutoff, but he recommends that in India, the diabetic capital of the world, 20 should be the cutoff value. But either way, this study said if you had a predetermined value of 30, look at the sensitivity and specificity to rule in MASLD was significant at the rate of 92 to 91%. And therefore, ALT alone was able to identify a subgroup of people who need to be kept on greater surveillance. This is the same that was pictorially represented both in males and females. ALT above 30 has a propensity to identify MASLD and the people who should be kept on surveillance. So area under the curve, 0.79 overall, 0.81 males and 0.69 females. ALT above 30 is a reasonable rule-in cutoff. If you now compare FIB4 to ALT, I won't take long on this except to say in this study, ALT outperformed FIB4 in detecting MASLD. FIB4 showed a weak or an inverse association. Now let's look at FLI. It was very strong and linear association. Higher values correlate with higher MASLD risk. And this is the pictorial representation. Cutoff 37 shows that these people with fatty liver index about 37 and above run the risk of developing NASH, and these are the people who need to be kept on greater surveillance. And very similarly, if the HSI of above 60 actually indicates that even if you had a normal blood sugar levels, these are the people who are likely to have diabetes mellitus, hypertension, and atherosclerotic heart disease. FLI 0.90, hepatic steatotic index 0.88 overall. FLI better in females, both effective screening tools to identify MASLD. This is the same pictorial representation, both in males and females, showing you that if you had a 37 cutoff or a greater than 60, the risk of these people to be kept on surveillance is the most important. So FLI and HSI better than ALT in non-obese MLD, and FLI and HSI performance is robust across subgroups. Now, I put this particular slide only to identify the case that I've discussed in the first. Now, if you have a significant steatotic liver disease, these are the people who develop cirrhosis liver and cancer. And we need to prevent HCC. Look at how the methods to identify HCC and to prevent them. Universal hepatitis B vaccine and treat chronic hepatitis B and Hep C. Hepatitis C screening is not part of any health checkup in India. And this is the graph. So look at the first person, doctor who had very significant S-soil that developed in the liver. Even after identifying steatotic liver disease, he always thought of steatosis, but never screened for Hep C. He had hepatitis C-related HCC. Now let us turn our attention to cancer. Do you have a health record that can actually detect cancer and screen you from the master health checkup? So this was a study done in Japan. Comprehensive health checkups in Japan are usually detection of cancer and metabolic diseases. And amongst the 23,128 comprehensive health checkup examinees, 1,760 were referred for some abnormality of their health check. And amongst them, 89 cancers were detected, which is 5%. All of them were in the early stages, and therefore, these, when they are detected, definitely prevents cancer. So now this is done across 1,700 facilities and 3.7 million participants annually. The medical records determine the cancer status post-referral. evaluate the cancer type, diagnosis, timing, and reason for referral, analyze the missed detections prior to survey. 89 cancers were detected, as I already told you, and it increased from 1.87 to 5.05% post surveillance. Cancer was more common in older and male patients. What was the cancer detected? The cancers were colorectal, stomach, prostate, and breast, and there was significant increase in identified cancers after the survey. Even during the pandemic, if you see 2019, 20, and 21, though the number of examinees reduced, the percentage of cancer detection continued to rise, telling you that the massive health checkup with some abnormality in the health checkup identifying cancer was most important. And what were the cancers detected? As I already told you, lung, esophagus, stomach, colon. This is across the body: renal, bladder, prostate, breast. Even patients with myelodysplastic syndrome leading to AML were detected from the health checkup. And the cancer stages during these health checkup was always early, and therefore, if you identify cancer early, you can improve their quality of life. What was the top references for referral? It was identifying fecal blood, an abnormality of abdominal ultrasound, chest X-ray, gastric X-ray, chest CT, upper endoscopy, blood counts, PSA screening, breast screening, and others. Now, I put this slide to show you that a chest X-ray, urine analysis, abdominal ultrasound, PSA screening identified significant amount of abnormalities. But then all these four are not part of the health checkup, especially fecal blood, PSA, are not part of the health checkup in our state. And we need to rectify this over the long term. So they concluded cancer detection doubled through medical records. Early stage cancers require more time for diagnosis, and comprehensive health checkup is essential for early detection, long-term follow-up, and improves the diagnostic yield. Abdominal ultrasound and PSA testings are crucial tools for cancer detection. This is across the body. Now let's look at what happens in gastroenterology. For identifying colorectal cancer, you need to do a fecal blood testing. And one of the most easy things to do is guaiac-based reagent. But in India, with so much of practices of gastroenterology and their lifestyle, the presence of parasites, fecal blood testing based on guaiac may not be the most appropriate to detect fecal blood. You need to have FIT. We'll come to that a little later. For gastric cancer, the targeted population should have screening endoscopy. For esophagus as well. And for pancreatic cancer, you need to have the US, which is the European position statement on cancer detection. Now let's look at value of screening endoscopy and the evaluation of esophageal, gastric, and colon cancers from MHC. Any screening test should be accurate, sensitive, affordable, practical, and patient-friendly. In 2012, look at the number of esophageal cancers and the deaths that are associated. And they expect that esophageal cancer is expected to increase by 140% by 2027. Amongst obesity, smoking, alcoholics, Barrett's epithelium, poor nutrition, and high temperature beverages. I don't have to tell you that in Kashmir, people will not be able to hold their cups of tea because it's so hot. They would need to have something else, but they would drink it, destroy their esophagus, alter the epithelium, and then develop esophageal cancer. Processed foods, and of course, sedentary lifestyle. And the high incidence in Southeast Asia undermines the reason why we should screen them. Now, how do you screen them? It can be by endoscopy, ultra-thin endoscopes, or capsules. No matter what test that you do, across the United States, United Kingdom, China, everywhere, the relative risk of detecting mild, moderate, and severe dysplasia and also cancer in situ is significantly increased by screening. And therefore, endoscopic screening is identified from massive health checkup, depending upon symptoms or abnormalities of tests. For gastric cancer, H. pylori eradication, especially in the high-risk area, possibly has mass screening benefit. But then, who should be screened? People with pernicious anemia, people who had a surgery on the stomach, especially if they had a gastroenterostomy. If they had some surgery in the stomach, they should be definitely screened by endoscopy. Familial adenomatous polyposis, non-polyposis colon cancer, and a positive family history of cancer. All these patients should need a screening endoscopy. I'm not here to tell you that white light, NBI, or perhaps chromoendoscopy. This is going to be the next topic, and my colleague will talk to you to identify early gastric cancer, which is the fourth in Japan. When you identify these abnormalities, And over years, if you screen them, you will definitely be able to identify the gastric cancer at all stages of development. A single screening is no use, and it needs to be repeated, especially amongst the population that I've already mentioned. And if you identify them early, look at the 5-year survival rate. Stage 4 is only 4%. If you identify at stage 1, it is 71% 5-year survival rate, and therefore we need to detect them early. Now let's look at feasibility of endoscopic screening in GI malignancy in patients in whom endoscopy cannot be done. For example, if there is a contraindication or the patient does not prefer to have an invasive investigation like an upper GI endoscopy, even screening has been done. And this study from Japan identifies GI cancer was detected 44 UGI malignancies, 0.4%, and 0.08% in even screening. Gastric cancer detection was 0.37% and 0.08% in the X-ray. That means somebody with a good screening method can detect CA even if the endoscopy is contraindicated. The advantage of endoscopy, of course, is that other malignancies like hypopharyngeal, esophageal, duodenal can also be detected. What is most important is GI malignancy detection is 1.23%. Gastric cancer detection rose to 1.03, and even other malignancies 0.19 in the endoscopy group after the propensity match screening. This is the pictorial representation over years identifying that if you have a screening endoscopy in the susceptible population, detection of cancer is possible from the tip of the mouth to the second part of the duodenum. And when you compare GI group and the X-ray group, you detect them early. You detect hypopharyngeal, esophageal, duodenal, and also GIST, while the X-rays in those people who are contraindicated is able to detect cancer in 0.08% of people. Now let's look at colon cancer. What are the tests? If you
Dr.
have,
Tayu, to
yeah,
interfere,
yes,
2 more minutes to go.
sure, I'll finish it off. For colon cancer, the screening colonoscopy is the most important, but then say a colonoscopy is not possible to be done at the mass level. And though you have fecal occult blood testing, which is annual FIT. Now, if you include FIT, is it that it actually improved the detection rate? This is a study done in Taiwan. The current annual volume is greater than 1 million. Positive rate of FIT is 80% detection of colorectal cancer. It increases the colonoscopies detection and the early stage detection of cancer by 50%. And the initial peak of CRC detection followed by a drop is due to removal of polyps. But then what is most important is that it didn't eradicate the cancer because there was prevalence of smoking in 40% of individuals between 41 and 50. And apart from the fact that you can remove polyps, external factors present will also be important in identifying colorectal cancer. So they said, FIT screening across ages and sex detects CRC, early stages of disease, and must be a part of all MHC-related universal healthcare in CRC prevalent countries. The last study. This was a study done in China. It is a very complicated study using artificial intelligence and, and the computers. There were 4 arms. There was no screening. There was only colonoscopy screening. There was an arm which had biannual FIT-based screening and what they called rollout FIT-based screening, which is a kind of a method by which you can calculate who are the people who really need to have colonoscopy either at 2 years or 3 years, depending. While the study is a bit complicated, I'll just go to the results. Results showed colonoscopy reduced CRC incidence by 55% and mortality by 63%. If you had FIT, it reduced by 22.4%. And if you had the calculation of rollout FIT, it reduced by 41%. What was most important? You had to screen, and a simple annual screening itself is important to identify colorectal cancer. The last. We have seen now MHC detects non-communicable disease, diabetes, hypertension, dyslipidemia, atherosclerotic heart disease. From the health checkup, you can identify cancer stomach, cancer colon, cancer in the esophagus, identifying patients for screening. What is the future? The future, it shifts from generalized to personalized checkups. You need to have AI-driven risk models that decide the test that you need. You need to just fill up a pro forma and AI will tell you what test needs to be done. There'll be integration of digital wearables, smartwatches, Fitbands, and ECG patches. There'll be real-world data that can be given to the teleconsultations and the remote health checkups that is likely to be a part of the mass screening. AI will help in radiology and in pathology. It'll interpret pathology slides better than us, and we can always confirm the findings. And public-private models accept. Now, this is going to be expensive, and therefore governments or non-governmental organizations need to subsidize the health checkup. It will be the corporate social responsibility that mandates HCV now for employees is likely to expand to their families and beyond. Smaller cities will see mobile vans, AI-assisted MNCs. Outcomes will be driven. For example, if there is an abnormality of the health, AI will tell us automated follow-up appointments. There will be digital health coaching, and of course, the EMR will be shared with the insurers for their own for identifying those people. There are challenges and there are solutions, but what is most important is the bottom line. The future of mass health checkups is smart, personalized, preventive, and data-driven. Focus not just on detecting disease, but on preventing it and guiding wellness. Well, I thank you for listening to me. It is important that we have a safe preventive health check every year, prevent disease, detect disease early, treat disease appropriately, and have a safe old age disease-free. And for that, we need to have a small change in the mass health checkup that we have. We do not have HCV, we do not have PSA, we do not have a urine analysis, we do not have a chest X-ray, and we do not have a stool test. And therefore, much needs to be done before we actually reach the masses across India or across the world. Thank you for a very patient hearing.
Dr. Cash, your comment before we start the next lecture. After that, we'll take up the question. And I see Dr. Gross also there. Welcome, Dr. Gross. Good morning.
Morning. Yeah. Thank you for having me.
Yeah.
Great to be here.
Want to make a small sum up comment before we'll start, then we can finally will take up all the questions and that thing.
Okay. Well, I will.
Go ahead, Brooks. Go ahead.
I was just going to make a quick comment on Dr. Thayu's lecture. Thank you very much. That was very illustrative and instructive. This has been a big topic throughout the United States as well. Lots of barriers and controversy with regards to this concept, as you mentioned, and you brought up and highlighted really all of them, is the large cost, the undertaking, and some of the questions I'll probably ask are going to be how we reach those underserved populations and the non-compliant patients that just won't cooperate, and then outcomes. How do we measure that and solidify that? And of course, there's also the question of changing leadership, amongst either national or regional, coming in and undoing programs perhaps that have been set up. How do we maintain a stability moving forward? So all of those, I think, are important topics for us to consider, but very interesting data, and really enjoyed your lecture. So thank you very much.
Thank you very much, sir.
Thank you, Dr. Cash. Now I will hand over the mic to Dr. Gross to introduce the topic and invite the speaker to talk on the pre-cancerous and cancer lesion screening methodology and rest of the thing in GA tract. Dr. Gross, yours.
Thanks very much. Really great to be here. Thanks for the invitation. I'm excited to hear the lecture by Dr. Sathamurthy on something that I think is tremendously important for our field, which is precancerous lesions in gastroenterology, screening methodology, and management.
Satya, you can start the sharing and
yes, sir.
start the lecture.
Yeah, is it visible, sir? Yeah.
Seen very well.
Thank you for the kind introduction, sir, Dr. Das. And at the outset, I would like to thank Dr. Chandrasekhar sir for giving me the opportunity to present and to share a platform with Dr. Seth Gras sir, who is pioneer in most of the guideline recommendations for the colorectal cancer screening and pre-cancerous lesion. So my job is to, in next 30 minutes, I will be presenting on the pre-cancerous lesions in gastroenterology, what are the screening methods and how to manage the detected lesions. So the topic itself is a very vast topic. So I would like to restrict my topic based the following points. Like I would like to talk on the global trends of GI cancer and how screening will be helpful in detecting the early cancers. and how a screening of the GI cancer evolved, and what are the common screening methods, and how to classify based on the risk. And I will be predominantly talking on the luminal GI cancers, predominantly the esophagus, stomach, and the colorectal precancerous lesions, and what are the endoscopic techniques of detecting these lesions, and how to manage such lesions, and how to follow up them based on the international guidelines. So if we see, the GI cancers constitute a major global health burden, and almost 1/4 of all the cancer incidents are because of these GI cancers, predominantly the five cancers: esophagus, stomach, colorectal, uh, liver cell cancers, and the pancreatic cancers. And almost more than 1/3 of the all cancer-related deaths are because of these five GI cancers. Among the five, the colorectal cancers are predominant, and the incidence has been consistently decreasing in the high-income group nations due to the vast screening methods and early detection of these cancers. And the sudden rise in obesity-related cancers are now because of that we see more of pancreatic and liver cancers. And there is a lot of geographical variation, and the Asia constitutes the highest burden for the gastric, esophageal, and liver cancers, whereas in the high-income nations like US, Europe, and Australia, there are high incidence of obesity-related cancers like pancreatic cancers and colorectal cancer. And we see more early the GI cancers, particularly in the colorectal cancer, which is happening in less than 50 years. And males have a twofold higher risk for all type of GI cancers. And key risk factors being the rising obesity pandemic and certain infections, hepatitis B, C, and H. pylori infection, and diet and lifestyle modifications. So why screening matters? We know most of the GI cancers are asymptomatic in the very early stage because they have a long pre-malignant phase. So it is our duty to identify such precancerous lesions before they become detected at a very late stage with poor prognosis. So the screening helps in the detection of these precancerous lesions. It can be diagnostic, and at the same time could be a therapeutic as well in the form of removal of the detected precancerous polyps. And early detection can improve survival, which has been consistently shown by the reduction in the colorectal cancer incidence, and also the mortality. And the 5-year survival rate has been excellent when it is detected in the very early phase, while it is very dismal in the metastatic stage. So we can able to identify the target population and screen them and detect the cancer, which is at a very curative stage, and thereby reduces the mortality also. We can able to by screening, we can able to address the early onset cancers like colorectal cancers occurring in the young. So the screening guidelines have already started to screen them at a very early age, like 45 years. If you see the chronological trend, how a GI cancer screening happened, so as early as 1930s, 50s, the pathological occurrence of adenoma to carcinoma sequence was identified. Later in 1960s, the FOBT test was introduced as a non-invasive test to identify precancerous lesions of the colorectum, and sigmoidoscopy was introduced for the detection of these early lesions, followed by a flexible colonoscopy, not only diagnostic, and it also removes the detected polyps. So the screening has evolved from detection to prevention now, and much studies later on by removal of the polyps has resulted. Many RCTs have proven incidence of colorectal cancer reduction and also the mortality in 1990s, and subsequently the population-based screening programs came into place. Not only colorectum, but also extended to the Barrett's esophagus for prevention of an adenocarcinoma. And improvement in the techniques and technologies happened in 2010 for increase in the detection rate in the early cancer phase itself. Now in 2020s, it is more of a algorithm-based risk stratification models are available, and precision screening is there. So the key message here is the GI cancer screening evolved from very early detection to true cancer prevention, and making the endoscopy as an important life-saving public health tool. So here we are going to discuss more about the precancer resistance of the luminal GI cancers, predominantly the esophagus, stomach, and large intestine. This is a list of precancerous lesions, especially for adenocarcinoma of the esophagus. The Barrett's is the only known precursor with low-grade and high-grade dysplasias. And for squamous cell carcinoma, the various low-grade intraepithelial neoplasia and high-grade intraepithelial neoplasia, and certain conditions predisposed to this should be identified to target the population for screening them to identify the precancerous squamous dysplasias. And in stomach, atrophic gastritis, intercal metaplasia, dysplasia of low or high grade, and some polypoidal adenomas, which later turn into gastric adenoma. So as in colon, adenomatous polyps and serrated polyps, and some dysplasias related to IBD. So if you see the squamous cell carcinoma of the esophagus, it is the most predominant cancer of all the esophageal cancers, constituting about 85%, whereas adenocarcinoma is only 15%. Predominantly, the esophageal carcinoma occurs in the esophageal cancer belt, and so they have in these high incidence regions, they have an invasive protocol like doing a high quality endoscopic examination to pick up the early lesions of squamous cell carcinoma, which are consistently shown reduction in the esophageal advanced esophageal squamous cell carcinoma, and therefore the mortality related to subsequent morbid surgeries. So we know the squamous cell carcinoma proceeds in a stepwise progression from low-grade intraepithelial neoplasia to high-grade and to the esophageal squamous cell carcinomas. But there are no established protocols for screening the for squamous cell carcinoma as that of Barrett screening for adenocarcinoma. The prognosis and survival depends on the stage of detection. So we need an advanced endoscopic imaging techniques to detect these early squamous dysplasia and targeted biopsies, and subsequently stratify the risk for screening and surveillance protocol. So endotherapy can eradicate the earlier places and can reduce the progression to invasive cancer. So whom to screen for a squamous cell carcinoma? In the high incidence regions, with multiple risk factors, especially lifestyle change, alcohol, tobacco, and decreased food intake, high vegetable intake, low socioeconomic status, and certain conditions like influence which have increased risk than the general population. These are the target populations whom should be subjected from the screening. And also the low-grade neoplasia and high-grade neoplasia, which have high odds ratio for development in invasive cancers. These are the patients who should be subjected for surveillance prevent than invasive squamous cell carcinoma. Certain conditions have a very high risk and poor prognosis associated or prior head and neck cancers, ileosis, and costic condition. These should be put under strict surveillance protocol. How to detect the early cancer squamous lesions? The standard white light endoscopy has many limitations because most of the lesions are very flat, which should be missed by naked eye examination. So we need an advanced endoscopy technique like a high definition white light endoscopy combined with chrome endoscopies. It can be a light-based chrome endoscopy or virtual NBI, which are more widely accepted. And the chrome endoscopy has a more reliable method for detecting these species with a higher sensitivity of 100%. And here, this picture shows the white light in contrast with the Lugol's the iodine testing, where the Lugol's iodine stains the normal squamous epithelium because of the glycogen content to brown, leaving the plastic unstained lesions. So, as far as possible, use the Lugol's iodine dichromodoscopy to identify. And if you have a magnification endoscopy combined with an NBA, and we have classification systems to identify early dysplasias. So it's so with magnification endoscopy, we can able to identify the early changes on the intraepithelial papillary loop patterns are very helpful for identifying and differentiating between the dysplasias. So these capillary loops undergo early changes like dilatation, tortuosity, and caliber change with amorphous formations. So we have many classification system based on the magnification endoscopy. The initial Inouye classification, ARIMA classifications are combined in the Japanese Esophageal Society classification, which subcategorize into type A and type B. Type A IPCL patterns are those with normal or and low-grade dysplasias, whereas type B
carries a high risk grade of high-grade high-grade dysplasias and invasive carcinomas. So we can combine both the dichroma endoscopy with an virtual chroma endoscopy to enhance the lesion, and mapping of the lesions can be done, and subsequently it is very helpful for subsequent endoscopic eradication therapy. So for esophageal squamous cell carcinoma, we need a high quality endoscopic examination screening at high risk populations, and any visible lesion should be resected and biopsy, and the confirmation is basically by the histopathological evidence of squamous dysplasias, which is graded depending upon the nuclear ATP to low grade intrathecal neoplasia or high grade intrathecal neoplasia. There is a role for the endo-ultrasound for assessing the depth of the lesion, and also for CT to evaluate for the regional lymph node and distant metastatic spread. And endoscopic therapy like EMR, ESD for the dysplastic lesion should be carried out. So coming to the Barrett's esophagus and esophageal adenocarcinoma. So we know Barrett's esophagus is the only precursor for adenocarcinoma, and mostly 90% of the adenocarcinomas of the esophagus are diagnosed outside the screening program. It means that more people has to be brought under the screening program to improve the detection of Barrett's esophagus, so that we can prevent subsequent development of adenocarcinoma. So screening not only leads the diagnosis, but also subsequent endoscopic treatment can be offered in the form of endoscopic mucosal resection or submucosal dissection or ablation of the low-grade dysplasias to prevent progression to high-grade or invasive cancers and treat the early-stage adenocarcinomas effectively. So whom to screen? There are variations in the guidelines, but no recommendation as of now to screen the general population. So targeted population or the high-risk population would be those patients with chronic GERD symptoms with at least 3 risk factors, predominantly male, white men, more than 50 years, obesity with a history of smoking, and family history of Barrett's esophagus or an adenocarcinoma. So how to screen? The gold standard is a high definition white light endoscopy with a virtual chrome endoscopy or a dichroma endoscopy with acetic acid, and following the random 4-quadrant biopsy using the Seattle protocol. But these are invasive, need sedation endoscopy, and there are also another invasive techniques like unsedated transnasal endoscopy and volumetric laser endomicroscopy, which doesn't require sedation. So there are other non-invasive techniques or advances in the Barrett's esophageal screening. We have the swallowable cell collection devices like cytosponge, EsoCap, and EsoCheck, esophageal capsule, magnetically assisted capsules, threaded capsule endoscopies, and the volatile organ compound analysis by the breath analysis, or the liquid biopsies to identify the microRNA patterns or the circulatory cell-free DNA. So during high quality endoscopic examination, how to pick up the dysplasias, the surveillance endoscopy should follow, and high quality endoscopic examination. Any Barrett's esophagus identified should be classified based on the PREX classification, the circumferential, the maximal extent, and the presence of hiatus hernia. Any visible lesions should be described based on the Paris classifications, and the number of biopsies, random biopsies, 4-quadrant using the Seattle protocol, or any visible lesion should be targeted biopsy should be taken from the visible lesions. So few words about the non-invasive screening methods. The cytosponge is the most studied non-invasive Barrett's esophageal screening technique, wherein polyurethane foam, 30 mm foam, which is compressed within a gelatin capsule, is swallowed by the patient, which upon entering the stomach dissolves within 3 to 5 minutes, releasing the spherical sponge. So while it is pulled up, the esophageal cells get collected. The collected cells are then centrifuged and made a cell block, and immunohistochemistry is performed with the markers, trefoil factor 3 and the tumor suppressor protein P53, which can detect a 10-fold more Barrett's esophagus. It is widely accepted because it's a less invasive procedure, doesn't need sedation. It may not require any physician to do the procedures. So mass screening, low-risk people, we can target the low-risk population to increase the Barrett's esophagus detection. So the other devices, EsoCap device is exactly the same, but it has a thick card with 25 mm sponge. And here, what we are detecting is the cell exfoliated cells from the esophagus are subjected for the marker panel methylated DNA markers, which is PCR-based assay. So the other is the ESO check, which is an inflatable balloon, which has an textured surface after inflation. So while withdrawing of the balloon, it collects the cells from the esophagus. And this also uses the MDM panel, which is also a PCR based. The unsedated transnasal endoscopy is through the nasal using an ultra-thin endoscope, but cavities, we will not able to take biopsies for the visible lesions. And subsequently, we need to subject them for if any lesions is detected, we need to subject them for an invasive endoscopic procedure. The esophageal capsule contains camera at the both ends, but we can't able to because of the unpredictable transit time and very rapid missed lesions are there. So the other advances is the third capsule endomicroscopy, which uses the optical coherence tomography, which scans circumferential esophagus 6 centimeter length, and subsurface screening can be obtained. So using the infrared rays, and now the AI also integrated with this can able to mark the lesions for subsequent endotherapy also. So how to improve the detection of dysplasia in Barrett's? So we have the clinical risk prediction models which can be incorporated, and also the advanced imaging techniques what we have discussed, and novel sampling techniques like the 3D VATS technology, where it uses a specialized aberration brush with AI prediction models, 150 micron depth of the histopathological specimen can be obtained, and the dysplasias can be detected with that. So artificial intelligence also helps for the detection of dysplasias in Barrett's. So the Barrett's International NBA group has came with the Bing criteria using the magnification endoscope with the NBI. So it is can able to distinguish non-dysplastic from the dysplastic. These are some of the normal microsurface and vascular patterns which indicates a non-dysplastic Barrett's. We should be familiar with these images before labeling it as a dysplastic or abnormal this thing. So the dysplastic Barrett's will be identified as irregular microvessel and irregular surface patterns. So how to screen, how to surveil these patients? So when the non-dysplastic Barrett's, there is low risk of progression to high-grade dysplasia. So the surveillance depends upon the length of the Barrett's identified. So if it is short segment Barrett's, can do a surveillance endoscopy after 5 years. When it's a large segment Barrett's more than 3 centimeter, the surveillance interval should be shortened to 3 years. So if there is indefinite for dysplasia, treat the patient with high dose PPI for 6 months and repeat an endoscopy, and repeat endoscopy findings based on that, follow the subsequent algorithm. If it is a low-grade dysplasia, second confirmation by second J pathologist, and patient should be offered either endoscopic ablation or surveillance should be offered at quick intervals like 6 months and 12 months. For high-grade dysplasia, there is high risk of progression to high-grade dysplasia, 8% per year. So after confirming from a second pathologist, the patient should be referred for endoscopic therapies to high-volume centers who deal with the Barrett's dysplasias. So endoscopic resection of the visible lesions followed by ablation of the remnant Barrett's esophagus should be the treatment options. And after the successful eradication, surveillance should be very quick, like after 3 months, 6 months, and 12 months for the first year, and then every year we should follow up them with a screening endoscopies. So coming to the pre-malignant conditions of the stomach, we know that the famous Korea cascade, chronic gastritis because of H. pylori infection leading to an asymptomatic precancerous histopathological changes like chronic gastritis to atrophic gastritis, subsequent intestinal metaplasia and dysplasias, and then progresses to the early gastric cancer and gastric cancer. So H. pylori is the dominant risk factor for non-cardiac gastric adenocarcinomas with an attributable risk up to 90%. And atrophic gastritis, gastric intestinal metaplasia, dysplasia, and certain gastric epithelial polyps are the pre-malignant gastric pre-malignant conditions. Atrophic gastritis is the most common gastric pre-malignant condition, constitutes about 15%, and gastric metaplasia in 5 to 15%, and the dysplasias vary depending upon the group of population we screen from 0.5 to 3.75%. And the most common in non-white individuals and immigrants from high gastric cancer incident regions. So how to screen? So screening is basically with an high quality endoscopic examination with an image enhanced endoscopy, and patients 45 to 60 years with high risk clinical high risk cases like non-white, immigrant from the high gastric cancer regions, families of gastric cancer, persistent H. pylori infection, smoking, and autoimmune gastritis. These are the high-risk clinical indicators to screen. And non-invasively, we can screen combined with the fecal immunoclinical testing with the H. pylori detection. And opportunistic endoscopy can be offered during the screening colonoscopy to detect these gastric pre-malignant conditions. So high-quality endoscopy examination in combined with an histopathological evaluation are the core for diagnosis and risk stratification of these gastric pre-malignant conditions. So during an high-definition white light endoscopy, these lesions can be identified as visible or invisible lesions. All the visible lesions should be biopsied, targeted biopsy, and non-visible lesions should be biopsy based on the standard gastric protocol biopsies, the updated Sydney protocol biopsies. The 3 mucosal changes should be identified endoscopically: atrophic gastritis, gastric intestinal metaplasia, and dysplasias. And endoscopy alone can't differentiate between the dysplasias and the early cancers. So systematic biopsy using the updated Sydney protocol is a must, and histological confirmation is needed. So we need to be familiar with the normal pattern with the white light endoscope and the image enhanced endoscopy to pick up these early lesions. So their normal surface patterns, the round pit patterns will be in the fundus and the corpus, and the elongated pit patterns in the antrum. Whereas the atrophic gastritis has a hallmark, 4 hallmark features of atrophic gastritis is pallor with an atrophic border, visible submucosal venules, and loss of gastric folds. And it is very prominent in the magnification endoscopy. The intestinal metaplasia can be identified as a focal raised elevated white patches with a tubulovillous mucosal pattern. And with magnification endoscopy, the 2 signs we need to look into: the light blue crust sign and the white opaque substance sign. And the dysplasias can be identified as irregular vessel or loss of surface pattern with an elevated nodular lesions. So this is the light blue crest sign, which are the reflections of the light at the epithelial margins, and the white opaque substance is a patch of white reflected light, indicates on the gastric intestinal metaplasia. So systematic gastric sampling, 2 separate sample containers should be used for the biopsies from the antrum and incisura should be in a single container, and from the body should be in another container, and targeted biopsies in additional separate containers, and should be subjected for the histopathological evaluation using the Olga and the Olgin system, which is operative link for gastritic assessment for the atrophic gastritis, and for gastric intestinal metaplasia is the Olgin. It is a validated histological staging system, which is very important, which incorporates both the anatomic location of the histological severity of atrophic gastric and intestinal metaplasia, staged from 0 from normal to a more severe stage, moderate to severe. Why it is important? Because the histological high risk groups should be kept under surveillance every 3 years Olga stage 3 and 4, whereas the intermediate groups surveillance between 3 to 5 years, and stage 0 and 1 no need for any surveillance. So this is how we risk categorize based on the histological. So dysplastic gastric premalignant conditions, the high-grade dysplasia is associated with the synchronous carcinomas and higher rate of progression. So it is estimated that almost all the patients will progress to an invasive carcinoma within 4 months to 4 years. So 1/4 will be diagnosed with an invasive carcinoma within a year. So they should be kept, whatever the dysplasia should be should undergo an endoscopic eradication therapies and subsequently followed with more vigorous screening protocols. So some gastric epithelial polyps, we identify polyps in 3 to 10% of all the OGDs, and the commonest is the fundic gland polyps, and followed by hyperplastic polyps and few gastric adenomas. Most polypoidal gastric dysplastic lesions arise in the background of gastritis and interstitial metaplasia. So biopsy of not only the polyp, but also surrounding mucosa and the updated Sydney protocol biopsies are indicated. So here are some pictures how to differentiate between the various polyps. And fundic gland polyps, if it is more than 1 centimeter and ulcerated, we need to resect it. Resection of all hyperplastic polyps more than 10 millimeters indicated. Regardless of adenoma size, all the adenomas to be resected, and no benefit after complete excision of the fundic gland polyp. And if the hyperplastic polyp more than 10 millimeters resected, so it should be followed by surveillance endoscopy at 12 months, and gastric adenomas within 12 months recurrence of the gastric interstitial metaplasia. Coming to the colorectal cancer screening, the most CRCs develop through the adenoma carcinoma sequence. So 70% of the sporadic carcinoma colorectal cancers develop from the adenomatous polyp. 20 to 30% also arise from separate pathway called the serrated, sessile serrated lesions through the SSL carcinoma pathway. So screening efforts are directed towards not only the detection but also the removal of the adenomas and sessile serrated lesion and the early gastric and the early colorectal lesions. So thereby the incidence and the mortality rates have come down because of this. So what are the screening methods for colorectal precancer screening? We have a direct method or one step, and two step method are the non-invasive methods. So gold standard is the colonoscopy, which can identify various precancerous lesions from early polyps to advanced adenoma polyps and early colorectal cancers, whereas the stool-based and the blood-based test I can identify only in the later stages of the. So these are some of the pros and cons of each of these, but the colonoscopy is 100% detection rate, and it is validated, and long-term reduction in the colorectal incidence and long-term reduction in the colorectal mortality has been studied consistently in more RCTs, and the once colonoscopy is done, the repeat intervals are very, when we can, in average risk individuals, it can be repeated after 10 years. So whom to screen for colorectal cancer? We can categorize into two groups: average risk category and high risk category. So those patients who have no history of colorectal cancer, adenomatous polyps, no family history of colorectal cancer, no IBDs, no suspected hereditary cancer syndromes, or no history of radiation therapy, they are categorized as average risk category. The screening recommendation is it should start by 45 years, either direct visualization using colonoscopy or a stool-based examination. If stool-based is used, FIT is the preferred one. So only single sample is sufficient. So it should be repeated every year. And FOBT test or a multi-target stool DNA test, which incorporates both the FIT and DNAs. So it should be repeated every 3 years. So if colonoscopy is performed in average risk category, it should be repeated 10 years. Flexible sigmoid for 5 years, and CT colonography every 5 years. So if they have a history of adenomatous polyps prior, or a family history of colorectal cancers and IBD, and the subsequent screening protocols is based on the if it is FAP, the screening should start at 10 to 12 years, and hereditary non-polypous colorectal cancers at the age of 20 to 25 years. And definitely a genetic testing and counseling is required. The recommendation is if more than 85, no need to screen, and from 75 to 85 years, it's personal preference. And less than 75 years, if their expected life expectancy is more than 10 years, and screening is recommended. So how to improve the screening? We should follow the guideline protocol for an high quality colonoscopic examination. The optimal colon cleansing should be adequate, so that the split preparation is the one which has consistently shown a good cleaning preparation, and the colonoscopist should follow the AGA guideline practice protocols. The cecal intubation rate should be more than 90% to 95%, and adenoma detection rate should be for men it should be more than 30, and for female it should be more than 20. The aspiration goal is more than 35. For identifying a serrated lesion, the goal should be more than 7%, and should examine the right colon, and the withdrawal time should be more than 6 minutes to increase the detection rates. And definitely should all the colonoscopes should be performed under sedation. And then additional value of technology has improved the adenoma detection rates, like having a new generation endoscopes combining with an virtual chrome endoscopy, and add-on tools like distal attachment caps, rings, and balloons, and addition of the artificial intelligence also helped in detecting the adenomas more. So once a polyp is detected using this high quality endoscopic examination, and the polyp should be classified based on the endoscope Paris classification, and if an NBA is used, the NICE type classification should be done. All polyps should be evaluated for the risk of an invasive submucosal cancers based on the Kudo pit pattern chrome endoscopy, or the NBA classification NICE 3 and JNet 3. These are indicates an invasive cancers. So that helps in subsequent planning of the endotherapy. So these are the pictorial representation of the Kudo pattern, NICE, and the JNet classification. So what we do if polyps are less than 10 mm, small polyps, a cold snare polypectomy is recommended as a safest procedure with no adjuvant treatment is required. If it is serrated lesion without dysplasia of more than 1 centimeter, a piecemeal cold snare polypectomy or a cold EMR can be safely performed without any additional adjuvant therapies. Where if it is a serrated lesion with dysplasia, and conventional EMR, that is submucosal injection with hot snare polypectomy, is the recommended choice, and it should be followed by a marginal terminal ablation of 3 to 5 mm post-resected area, and if it is in the right colon, a clip closure should be performed. If it is a medium-sized adenos from 10 to 19, conventional EMR hot snare polypectomy is the ideal choice, and it should be followed with a marginal thermal ablation using the snare tip coagulation and clip closure in the right colon. So this is an example of a polyp which is there in the transverse colon, very small polyp Paris 2A, NBI, and the cold snaring and is performed in that. So if it is a SSL of 2 centimeter size in the ascending colon, right colon, so submucosal injection, lifting of the polyp, and then subsequent hot snare coagulation is, hot snare polypectomy is performed, and subsequently treated the margins with thermal ablation using the snare tip sharp coagulations, and subsequently clip closure is performed because it is in the right colon. So for larger adenomas more than 2 centimeter, conventional EMR or an adjuvant techniques like underwater EMR or ESD if we suspect any high risk for submucosal invasive cancer, and subsequently it should be followed with the adjuvant therapies to prevent the recurrence. In rectosigmoid region, ESD is the preferred one, whereas proximal to the rectosigmoid, surgery should be subjected. This is one of the example. So this is the same thing what we have discussed in. So subsequent to the polypectomy, how to follow them up? When there are hyperplastic polyps less than 1 centimeter, the next screening colonoscopy should be 10 years. whereas 1 to 2 adenomas less than 1 centimeter, 7 to 10 years. Serrated sessile polyps should be less than 1 centimeter, 5 to 10 years. 3 to 4 adenomas of less than 10 mm, or 3 to 4 sessile polyps less than 10 mm, or a hyperplastic polyp more than 1 centimeter should be followed up with a colonoscopy 3 to 5 years. So when there is an advanced adenomas or sessile serrated polyps more than 1 centimeter with villus histology or tubulovillus histology or high-grade dysplasia, the surveillance colonoscopy should be at 3 years. And if you detect more than 10 adenomas in the screening colonoscopy, the next surveillance colonoscopy should be at 1 year. So most GI cancers are preventable, and risk stratification can help in identifying these precancerous lesions. Incorporating the AI risk prediction model can also help in identifying these cancers very early, and endoscopy is the central with a high definition and high quality examining following the standards of the ASG, ACG, and AG guidelines. And organ-specific screening protocols must be followed, and histology is mandatory, which also gives risk stratifications and helps in the endoscopic resection and surveillance protocols. And endotherapy should be the first line offered for these early lesions, which is organ preserving and curative. And surveillance interval should be guideline driven and not arbitrary. And multidisciplinary approach is essential for high risk lesions. And following the quality indicators can improve the detection rates. And future is the precision screening using the artificial intelligence, personalized surveillance, and molecular markers based. Thank you. So detect early, treat endoscopically, and surveil them wisely and prevent the cancer.
It's really fantastic, Satya. You gave a full, it's a difficult topic, a very comprehensive discussion. I think we'd like to have Dr. Professor Seth Cross comments, then we'll start the panel discussion. So what is your
Thank
take?
you.
A lot of
That
work.
was a really high level overview for a lot of different areas of healthcare prevention. I think, when I think of this, when we talk about colorectal cancer, you may have seen recently that colorectal cancer morbidity mortality in the United States is the number one cause of cancer-related death for men and women under 50. And we've lowered our screening age to 45. And so I think awareness is really important. Most of those people get diagnosed quite late. The other thing, for some of the other areas where we don't have dedicated screening programs, looking for Barrett's esophagus or even squamous cell cancer, I think it's critically important to get a good history, to identify those high risk patients. Take the time to talk to your patient. We shouldn't just be thinking about doing the procedures. And when we do these procedures, we really need to make sure that the individuals that are doing them are well trained, know what to look for. Lesion recognition is critical because, as you've nicely highlighted, the earlier we identify something, the more likely we will be able to eradicate and cure that patient. Very nicely done.
Thank you, Professor Seth. Now the panel discussion, the format here is we'll start from the first moderator, Dr. Cash. You can give comment or question. You can take up the question from the registered delegate, or you can ask, your own comment, and followed by Dr. Said. Then we have panelists Dr. Kotari and Dr. Jayant and Dr. Sahin. Then we'll have a 3-4 rounds of discussion. Last 10 minutes we'll wind up. Okay. So starting with Dr. Cash.
Okay, thank you very much. Dr. Thayu, I wanted to ask, you mentioned several times leveraging artificial intelligence to try to, accentuate and optimize the master health evaluation. Where, if you had I won't say an unlimited budget because that's unrealistic, but where would the first efforts with that go? Where do you think that the most value from leveraging artificial intelligence would be? Would it be towards interpretation of some of the tests, such as ultrasound and some of the radiologic tests or the labs that you mentioned, or would it be identifying individuals to participate and reach out for getting them enrolled in such a health evaluation?
Yes, sir. It's two ways. The first is that I think in the future, what you need, a person who wants to have a health check would perhaps fill up a pro forma or an app, And then the AI will probably tell him what tests are important for you apart from the routines. That's one. Second thing is today, I think artificial intelligence is interpreting radiology and pathology has almost become a routine. And therefore, a better interpretation of a chest choreography, or perhaps a biopsy, or perhaps even abdominal ultrasounds, CT scans. I think that would be the starting point. And I think it will evolve over time. And perhaps there'll only be human superficial surveillance, while the artificial intelligence actually gives you the answers. Perhaps that's probably the way to go.
So my follow-up question to that would be, are there currently adequate resources to achieve that? And if not, when do you think that might be a reality?
This is an extremely difficult question to answer. There will have to be corporate social responsibility. The government and the non-governmental organizations will have to strengthen the healthcare system, introduce AI at least in stages, identify the people who need it, and then I think we'll have to go about it. It's going to be a long term. And I remember Elon Musk telling us that future there'll be no medical people. Robots will handle everything. That seems to be his. So maybe he will be able to give us the best answer.
I will ask him when I see him. Thank you.
I think AI is going to be supplementary right now, and the human brain only creates kind of AI. I don't think it will replace it, and no empathy and sympathy and the emotional factors will not be there with AI unless they have been trained for that also. So it's a long way to go if it is going to be true what Elon Musk said. Now we start with Dr. Thank you, Dr. Akash. We'll come back again. Dr. Graz.
Sure. The one thing, just piggybacking on the whole artificial intelligence, it's something I think we're very excited about. One of the things that we've seen recently in endoscopy, for instance, is this fear of de-skilling. They talk about de-skilling for the physician in practice in the notion for colonoscopy, where you work at a center that has an AI-assisted colonoscopy available, and then you switch centers and you go to another endoscopy unit that does not have artificial intelligence, and they've actually seen a drop off in performance for polyp detection. If you look at it even more globally in terms of artificial intelligence, how do you both feel AI should be integrated, not just for trainees, but for physicians in practice to not lose that skill that we've all spent decades trying to master?
I think the uniformity is not still there in most of the advanced countries too. As you said, some unit may have AI, some may not have. So the kind of the thing is needs long way to go. Dr. Thai, you want to make a comment? Dr. Satya, you want to make a comment on this?
I would like to just ask our foreign guests. Now, you say AI. Okay, now who's going to take the legal responsibility? Now, if you say that AI did this for me, now today, if you missed a colonoscopy finding, then you're responsible. But if they say the AI is going to do everything, then who takes responsibility? So I think there are a lot of legal issues before we actually turn to AI and say they will completely replace. It's going to be very difficult.
I don't think, for right now, where we're using AI in the US, it's not so much that AI is fully taking control when I do a colonoscopy. Ultimately, I am still encouraged to do my regular exam, and it may draw my attention to something. So at the end of the day today, I still feel solely responsible, if there's an interval colon cancer, for instance. Now, you're right, there could certainly be a future state, right, where AI, does a capsule endoscopy exam and the physician does not even review any of the still frames and they just sign off on it. Again, I think that physician, would be responsible, just like we're responsible for physician extenders and other people in the medical team. If unfortunately something is missed or something, something happens. I guess what I'm trying to to figure out is what will be best practice, for integrating artificial intelligence without compromising the physician's role in patient care. You're right. There are going to be certain things that are completely automated, but I also think that that's still a ways away. And for most of us, we will be in partnership with AI versus solely dependent. But I will say, even in my own practice, I work at two places. One has AI and one doesn't. And sometimes when I see a polyp in the non-AI endoscopy unit, I'm like, wait, there's no box. And I have to remind myself because we don't have it in this particular endoscopy center. So that's why it's so important to stay engaged in whatever area of medicine we're working on if we're incorporating technology to enhance our performance.
Thank you. Dr.
Uh,
Satya, you comment?
Yeah. Yes, sir. Still, colonoscopy skill is mandatory because the AI can detect unless we focus the lesion, then only the AI can guide you the detection and also this what is the type of polyp we can identify. But to reaching the CCOM, cecal intubation and everything is should be followed, and still we require a physician skill there to reach and to show the polyp, then only the AI can detect and can diagnose it.
Yeah, I think you bring up a good point, specifically to colonoscopy, which is surface area exposure is very important because right now AI algorithms can only evaluate the surface area of the mucosa we show it. And if we don't show it and it's behind a fold, then then we're going to miss that polyp, and actually it's going to make it look like AI is ineffective. There was a study I was a part of a couple years back using EndoCuff plus AI versus AI alone, and the EndoCuff AI arm outperformed AI because of, to your point, that whole idea of good technique and surface area exposure.
Yeah, the technical skills cannot be taken over by the
Yeah.
AI. So rightly pointed out. Again, right now when the AI is evolving, the physician in charge, the consultant in charge is accountable. So you can't blame it on a machine and say that you can get away with this. I did not do that. The AI only should have picked up. No, we have not come to that stage. Dr. Kotari, your
Yeah,
question.
no, great discussion and great presentations. So, Dr. Gross's point, at our institution, the trainees in their first years and almost in mid of their second years, we don't let them switch on the AI box. And the analogy I use with them is, when we start to drive, and if you just rely on GPS, you will never pay attention to the street names and where you're going. So, I think it's important for us to train our trainees in the basic skills, looking behind folds, doing a great exam, and then they can augment their training and that strong foundation with AI and how to incorporate that, and be in sync with the new technologies and adapting that into their practice wherever they go. But that strong foundation of good skill set, reaching the CECUM, and good techniques and looking behind folds are all key essential of their foundations.
I think that is a very valid point. Today I'm in Patna, the new city. I'm supposed to go to his hotel. So I asked my driver to take me there. So he's a young man, and I did not know where the hotel is, and his GPS was not working. So he was helpless. So actually, what happened is the hotel is just in front of the airport. So he was not aware of that. That means, so once you are addicted to GPS, you are not even knowing the nearby. Like that, what you said in first year, you should not use the AI tool. Get the technical skills right. Make sure that you have adenoma detection rate is good. That's a very valid point. I appreciate that. Dr. Jayant, Dr. Ghosh, unmute yourself, and Dr. Next, followed by Dr. Sahin, then Vivek, Rajiv, Lamba, Greece, Mahapatra. So many people have a
Yes, sir.
question. Okay.
Sir, what I think, like for the master health checkup in our country, uh, none of the like any of the insurance companies, they are not covering the master health checkup. The largest amount of insurance in our country is provided by the Ayushman Bharat program by government of India, and they are covering around 55 crore, that is around 40% of the Indians, and they are providing only 5 lakh rupees for treatment in a year. None of the private insurance companies, although their coverage rate is around 4 to 5% of the total other population, Indian population, they are also not covering the for any master health checkup programs. So none of the
Very
government colleges, they are not having any master health checkup program. So how can we implement this? I think before going to AI, we should have our own programs, and which should be based on X-ray, stool local blood, hemoglobin, platelet, LFT, which are reality, which could be done to the general population. And that what I think. And we should develop our own system to have a master health checkup. We can definitely provide for the some health checkup to the better well-to-do families, well-to-do program, but not to the as a whole. We cannot plan like this. What I
I
think.
you are right. Most of the people admitted for diagnostic investigation, including colonoscopy, the insurance is not taking care. Number one. And number two, only those who can afford out of pocket expenses only you are able to cover this endoscopy screening methodology. Number two, why I think we have to take it in a large representation to the various insurance company. You add more premium or whatever you want to do that has to be taken care, and we have to appraise the government agencies also to include in the Aishman Bharat or whatever you said the screening methodology. I just want to ask
Yes, sir.
my who have come from abroad. Dr. Said and Dr. Kash and Dr. Kotari, what is your policy in USA covering this screening methodology by insurance?
Well, I'll jump in briefly. So it's mandated by the government that private insurers, after a certain date, cover preventative tests, and that includes, and specifically cancer screening, and that includes breast cancer as well as colon cancer. There's some companies that actually will screen for cover lung cancer screening as well. Those are the major things. Now, prostate, no. Other preventative tests are often covered. Preventative therapies such as flu shots and things like that are free generally. But the concept of a master health checkup is not widely embraced for the exact reasons that Dr. Ghosh just mentioned, the feasibility and the economics, in addition to poor uptake, lack of outcomes data showing benefit, make it problematic. And so from a feasibility standpoint, currently, it's very difficult, but we have rules that mandate coverage for certain preventative screens with regards to malignancy in the US.
Yeah, and the other thing I would just jump on is that in the US, we're also seeing, a lot of patients getting these full body scans, not necessarily ordered by any of us, but it just leads to a very big workup for these incidental findings that often have no clinical significance. So that's the balance, and to what was talked about with prevention for precancerous GI malignancies earlier. I think that's why identifying these patients, I think a lot of it starts in the primary care office, less so for us because we're not necessarily going to see these patients, who go to the primary care office, or if it's females that go to the gynecologist, and if they're having symptoms of chronic reflux, etc., and they meet the age criteria, we need to get them referred, to endoscopy, for instance. But there's a lot of missed opportunities out there. But I think a lot of it stems from at the level of the primary care, which those folks are the first line in our healthcare system.
Yeah,
Okay,
I would agree with that. This has been around for 20 plus years, and we used to call it millennium scans. It's because it came around 2000, and people would go just get a whole body CT, and now it's even progressed from that. What Dr. Thayu mentioned was some data. He presented some data finding earlier malignancies, and we actually showed something similar when we were pioneering CT colonography when I was at Bethesda, and we showed that we did find more cancers, and that we did find them in an earlier stage, renal cell cancers, things like that, that were intervenable, that probably would have led to some of these patients' deaths. That being said, there's very little evidence right now to support those types of concepts. So we need more data to prove that this is something that's valuable. But as Dr. Groth mentioned, it's a real slippery slope, if you will, with regards to the economics and patients. There needs to be huge, significant barriers or guardrails around additional testing from incidental findings.
I think with the rate going around, those who can afford only can undergo pre-cancerous screening or whatever. So I think we need to take up international level. What is Dr. Kothari? What is your opinion? And I just want Dr. Sahin to start the question after that. Dr. Kothari,
Right.
please.
No, I agree that's been said so far that the economics and the balance between these scans and what gets picked up and what gets followed. And I do my fair share and we're involved with registries for high risk pancreatic cancer screenings. And again, you have to make sure these are carefully selected patients, that you're doing these invasive EUS or MRIs, and they do have a strong family history and are at a higher risk than the general population. So yes, the targeted groups where you feel these are high risk, and we screen those. And of course, we are not even tapping into the patients that truly could use Barrett screening and colorectal screening. And I always tell my fellows that the best screening test is the one that gets done. So I think we still need to do a great job at the cancers that are already out there. And with colorectal cancer mortality being as high as Dr. Gross mentioned earlier, is to motivate the patients and get them to screening for the cancers that are the screening that is covered by these insurance companies. Leave aside doing these whole body scans and whole checkups. So I think that motivation at the patient level and education is really important.
Thank you. Now, hereafter the rapid fire rounds, brief question and brief answer. Dr. Sahin, your time now.
Yeah. Thank you, sir. Yeah, I just want
Can
to
you
say thank you.
louder? Your
Yeah, thank you, sir. I'm honored to be the part of this session with the stalwarts of gastroenterology. As has been already discussed, point is how to balance this comprehensive testing with cost effectiveness in India. India is not a country; it's akin to a mini continent, because diversity is so much and numbers are so much. I mean, it's so huge. So how will we cater this much MHCs and screening when we are not even able to cater the symptomatic, critically ill patients? Because obviously we have big centers, but masses don't get most of the people don't get the basic facilities. So what is the practical solution to this, to midway to this?
I think this is you can't do screening once you are done with the critically ill patient. That should go on like that. And side by side, we should start developing that. And diversity, we have to identify group or 7 group. Accordingly, we have to tailor made master checkup. We have to do that. So I do agree with you. Number of patients are so much, and the volume so much, and we don't have the finances to take care of that. Even a critically ill patient, how to talk
Yeah.
about the no, this should go simultaneously. I think we have to start some program. And we have a question from Greece, Vivek and Lamba. You have a question? Dr. Vivek Lamba, Krish, or we'll move on to the Dr. Mahapatra, Rajiv, Praveen. Okay, now we will start the second round with the Dr. Cash. Now, hereafter, a brief question and very.
Okay, let me see if I can come up with a brief question. What's the status, Dr. Thayu, of liquid biopsies in India? Are they approved? Are there any tests available? Are they being used?
They are being used in corporate hospitals. It's going to be for a very, very select few of the liquid biopsies, especially circulating cancer cells, are being identified. Patients who have had this neoadjuvant therapy and then followed by, let's say, surgery. Then one of the methods by which they screen is liquid biopsies. And it is done for a very few, and it is done only in corporate hospitals. It is not done in any government hospital. It's very difficult to get it done as a matter of routine. It's only for the high elite. It's only for the high elite who can afford it. And most of the times, even the insurance companies do not cover this. They do not cover this.
Can we take up some questions from the delegates which you have asked? How do you assess there are so many master chef packages. So how do you choose your package? Or you uniformly do one?
No, I mean, you're asking me?
Tayu.
Yeah, see, actually, you don't get to choose. That's the problem. Now, if you go to a lab-based mass health checkup, or a corporate hospital-based master health checkup, they have packages. They have executive health check, women's health check. But then the basics that are available, which I've already showed you, it does not have an X-ray, it doesn't have urine, it doesn't have PSA, it doesn't have abdominal ultrasound, it doesn't have fecal blood. And that's the three cases I told you.
I
Now,
think we have to make according to the gender, age, and the kind of the high risk population. We have to do that.
correct. Now,
So,
if you do a basic health check, and I would think that you definitely need the following, which I have tabulated: CBC with ESR, liver function test. Even the full liver function test is not necessary. AST and ALT alone can be done. Thyroid profile, sugar and HbA1c, because India is the diabetic capital of the world. HbA1c and anti-HCV should be part of the program. You should have an abdominal ultrasound and X-ray chest, urine analysis, stool occult blood, and PSA. This should be identified, and a reasonable rate of about 2,000 rupees. Unless you do it for about 1,500, 2,000 rupees, it becomes unaffordable. So this is what I need to do. I told you about the doctor who was routinely following up, developed HCV because HCV was not screened at all. He only had steatotic liver disease, and he thought it was he had only NASH.
screened in most of the basic master checkups. Say most of the basic master checkup done to pick up the metabolic syndrome, only diabetes, hypertension, and other thing, hypercholesterolemia, and all this thing being treated. But I think we need to go for a screening in our hospital institution. We do that. Those who need to have a cancer screening, those who need to have the metabolic syndrome, and those who need to have the additional the genetic disorders like that.
There
Okay.
is one point I like to make. It is not just an one-off mass health checkup. It has to be done at intervals. And unless you do that, it's not going to become cost effective at all, or it's not going to be useful to the patient.
Okay. And Dr. Gross, your question, or you want to take up any comment now?
Sure. A quick question for Dr. Sathamurthy. You talked about the non-invasive cell collecting options for Barrett's esophagus. Where do you see that being offered for patients? Do you think this is something that we'll be doing routinely as gastroenterologists, or is the better side of service the primary care physician to offer that in their office and then refer to us? Or both?
Yeah, it can be done as a mass screening program without the need for the physicians. So to pick up the low risk populations. So always the high risk populations, you need a quality high endoscopic examination. Invasive is better. To pick up more risk patients, we can offer an office-based, because the acceptability and the tolerability to these non-invasive procedures to the population will be better. So we can include them subsequently if they are detected risk of any Barrett's, then we can subject them for an invasive procedures. Basically, it is being practiced only in US and UK. We don't have wide applicability. So in the high risk regions of Barrett's, so it has been tried.
Thank you.
Dr. Satya, there is a question for you.
Yes, sir.
Any molecular biomarkers available as a cancer screening methodology?
Yes, sir. Liquid biopsies based on the cell-free DNAs, specific for the location of the GI cancers, and blood-based biomarkers for colorectal, are there available, but it is not widely applicable because of the high rate, not for not validated. The sensitivity is still low. The initial screening methods we can use, but not as a mass screening.
Confirmatory, you mean?
Yeah.
Okay. Dr. Kothari, you want to ask a final comment before we'll move on to the others? Yes.
Yeah, I think also now with the advent of, especially for Barrett's, we have risk prediction tools based on the biopsies, and then that this could help risk stratify patients where they would go on to more invasive treatment versus downstaging their um, uh, management protocol. So again, I think all these tools and the advancements in the field are only going to help tailor make our therapy with shared decision making with the patients. Like Dr. Thayu said, it's not one and done. This is all discussion and tests in progress if we really want to see an impact and outcomes for the patients.
Here I just want to draw your attention. Should be made according to the geographical area where the kind of cancer you see more. We hardly see Barrett's esophagus, and so there is no point in we can't tell the government, okay, we will have a screening program for the Barrett's adenocarcinoma. So that's Dr. Lamba, you want to ask some question, and we do have, see esophageal cancer and stomach cancer much more than the hepatocellular carcinoma. And you take northern part of India, gallbladder cancer is more, but you take southern part of India, cholangiocarcinoma is more. So we need to have an in-depth understanding, and most of the time, cholangiocarcinoma, when we see that, it is an inoperable state. So unlike the other, so even the gallbladder cancer also sometime. So we need to have the master checkup screening program tailor made to the need of the country, and we have to have a policy. Then we have to take it to the insurance company. So these are the areas we need to cover them. So yield will be more and the benefit. Dr. Jain, followed by Dr. Sahin. Last question from your side. Brief question.
So, sir, it was very nice debate and everything was very good, sir. Only one thing what I think that what you told me, that what you told in the discussion, that it should be based on our region and we should develop our own data. We should have our own data before going to government or going to the insurance company, sir. What I think. But yes, sir.
The need of the hour now. I think all the senior, junior who are in the academic situation and the government institution, private, corporate, or a private practitioner, or individual consult, everything should get input from them, and after that we should frame a policy. Dr. Sahin, I understand CS stomach is very common there, oral cancer is very common there.
Yeah,
In fact, much more
esophageal cancers are very common here,
oral
and
cancer.
there's something I mean, there's something peculiar about the cancers in our part, because like we take a lot of salt tea, we take a lot of noon chai, which is called noon chai, and that has been seen one of the risk factors for the esophageal cancers, and that's why our patients don't have disparity. Male and female are almost equal in incidence and prevalence because of this. And peculiar thing is that we use congrees and they cause the skin cancers and all those things. So it is very, very important to risk stratify according to the region and get the basic data and then follow. And we need to have data for the adequacy of colonoscopy also. Even in those patients whom we risk stratify, we do the colonoscopies and we do the endoscopies, but are they up to the mark? What are the pitfalls? What are the missed rates? What are the interval cancers? That is to be seen.
Yeah, I understand that there should be dietary variation is there, some climatic variation is there. You eat hot food and you gulp the hot tea also, then esophageal cancer very good. And you are in a cold place where you need to warm up yourself and take that. And South India, they take a lot of pickles also. Their pickles not one of the risk factors for developing cancer of the stomach. I think we need to take all into account. Now, last 10, 5, 7 minutes, I'm going to ask something very interesting. Dr. Lamba, you have a question? Grace, Vivek? If not, then I just want to know, this is going to be a little lighter session and we want to know more about you.
Personal.
Doctor, I'll start with Dr. Cash, which is a
So you want
non-medical. Yeah, we're going to start now. And
non-medical? Okay.
the webinar,
Well,
we have 39th webinar we are conducting under the endorsement of ACG, and it has become very popular all over the world because of the content and the faculty and the kind of topic we have really taken into. This is the one of the dream topic for me, and I'm going to write an editorial now to the not the scientific. I want to write it in the magazine, the daily, the newspaper magazine. I want to write on master checkup how to screen. So we have to start from there. Then I'm going to address to the insurance company and the government agencies. This whatever discussion, I'll put it as an input there. Now, Dr. Cash, what is a non-medical book you have read recently? So that
Oh gosh. Let's see. I just had it in my bag. I'm reading. I'm reading a.
ultra.
I'm reading a book on leaving a destiny. So what is my destiny? And it's about basically leading your family and your friends and trying to make a mark in the world and for good, as opposed to just making a mark for self-aggrandizement. So leaving a lasting
The top
destiny for benefit for others.
Dr. Grass, what is the non-medical book you have read?
So there's a book that I read called 0 to 1, and it's about the startup world with PayPal and Elon Musk and Facebook, and how those companies really did not have a lot of money when they first started. And for instance, with Facebook, Mark Zuckerberg wanted to have this mural in the office for Facebook, but he couldn't pay the person to paint it. So he gave them shares in Facebook before Facebook became this global entity and became Meta. And those shares, ended up being worth millions and millions of dollars for this particular person that drew this mural. But what it taught me is that you can't keep everything to yourself, and the way you move things forward, move ideas forward, is you have to work as a team. And if you want to try to keep everything, you end up with nothing. But all the people that have been successful in this book shared early on by giving, I guess, sweat equity in what they were working on, and everybody became successful.
This is akin to the book I read, Die Empty. So watch it, share it, and when before you take off, everything should be shared with every skill, knowledge, money, everything. And Dr. Kothari?
So mine, I mean, the book I'm currently reading, it's called Perspectives, and it deals with various topics in life on, what your definition of happiness, success, things in life should be, and just I think making the most of each day, keeping it simple, keeping it humble, and I think those are the life lessons. So yeah, it's a very beautiful book called Perspectives.
uh, Philosophical. Dr. Gross is motivational. Yours is management. Dr. Ayu, what's the book you read?
Actually, I'm far from whatever has been said. I read fiction, and whenever I go to the United States to spend time with my children and
Okay.
grandchildren, I read a book by Michael Conley called The Laws of Innocence. Now, I was intrigued by the title. It said Laws of Innocence. So it's about a lawyer who gets framed for murder, and he goes to court, and the court acquits him and says, "You're not guilty." So the lawyer asked, then who is, I'm still not innocent. No, I have to be innocent. You just declared me not guilty. And so he goes on to identify the murderer. And therefore, there's something called the laws of innocence. Simply being not guilty is not innocence. So
Okay.
I was terribly impressed with the title. And the book was very intrigued. Very, very intrigued.
And the kind of philosophy. What is Satya you have read?
So my native language, Tamil.
I'm not giving
So,
time to read all these things. You have my face.
Ponniyin Selvan is a Tamil novel by Kalki. So after seeing the movie only, I started reading the novel.
That's a national award winning
Yeah.
winner movie. That is a great novel by a novelist in Tamil local language. Incidentally, for those who are not aware of the language, the oldest language in the world. What is that oldest language? Can anybody guess?
Tamil.
Tamil. Yeah. Who said?
Me.
Everybody says.
No. You should not say. You should ask. You telling is no me. Okay, Dr. Sahin, what's the book you read?
Yeah, I read a book that's called The Things You Can See Only When You Slow Down. That is by a Buddhist monk. His name is Hemin Sonim. So we need to actually slow down because we are bombarded by so many information, so many things to do and everything. But we need to be mindful and relish the happiness in gratitude and peace.
Okay. Dr. Jayant, any book
Yes,
you
sir. Yes, sir. I'm just
have time?
reading right now, sir. India, comma India, Bharat and Pakistan, the constitutional journey of a sandwich civilization by J. Sai Deepak. It's very
Okay.
interesting book, sir.
Okay, Lamba, what book you have read? And the Grish, Mahapatra, and Vivek. Okay. Now, next question is, who is your hero, Dr. Cash?
Oh gosh, I'd say my my hero would be my father. He left me
Father.
with, yeah.
Dr. Gross, who is your hero?
That is a really good question. I don't actually have one person because there's been a bunch of people that have been influential to me, both personally and professionally. So I don't have one. I take a little bit of the best of everybody to try to, put me in the position I am today.
Okay. Dr. Tare?
Again, there have been many influential people, but I can say the first one would be my mom. Very strong woman, and raised me to be a strong woman too.
Okay, Dr. Tayu?
It's very difficult to say who's my hero because it could be my parents. But I was very impressed with Roger Federer. Now, that's because of his humility, his grace, and his exponential tennis skills that we see on the court. Remember, he retired, and still in the Australian Open, he seemed to be the most favorite player.
Who is very hero?
Yeah. Roger Federer.
Okay, you are. Now, Satya, I'm asking.
Oh, yes, sir. So definitely the real world hero will be my father. And if you ask in movies, then Kamal Hassan.
Okay, so movie and real life, you are classifying like that. Okay. Very hero. Okay, well, you are thinking about hero. Jayant, who is your hero?
Sir, both of my parents, sir.
Oh, parents, okay.
Yes, sir.
Next question is, Cash. What was the turning point? You think that break in your life, and after that, there's nothing to look back. What is that? Quick.
Marrying my wife.
Marrying, huh? Marriage is the turning point. Dr. Gross?
I'd have to say the same thing. It completely changed my perspective on things.
Hope
Plus,
they
she's
are
sitting next to me.
hope they are watching, and you will get a nice. You will really enjoy the. Okay, Dr. Kotari.
I will split it into, I think, professionally getting into my GI and advanced fellowship, but I think as a person, becoming a mother, I think that was a very monumental moment in my life.
I think becoming a mother is a great turning point because I love that motherhood. The whole world exists because of the motherhood. Tayu, what was the turning point in your life?
I'm not very sure, but one thing I want to tell you is I never wanted to become a doctor. In my schooling, I had taken algebra and geometry as my elective subject. And when I reached Mijora College to study my pre-university, my father, being a friend of the principal, had already dictated that I should take natural science. So when I went to the college, the principal said, "You've already been chosen for natural science." So I later became a doctor. I don't regret it anyway.
So, nothing to regret, but you would have missed a gastroenterology, a good gastroenterologist had you not come. Satya, what is your turning point in your life?
While doing my MD, I was posted in endoscopy. So that was my turning point to select a gastroenterology as
Because of your posting. What about science?
Yeah, I think being mother and parenting my children has been the game changer because that makes us a better human. We groom ourselves.
Jayant, what is your turning point?
Yes, sir. Same. That is my when I become a parent.
Oh, you become a father. I mean, okay, right. Which is your favorite movie, Dr. Cash? If you watch movie?
Oh, my favorite movie, Field of Dreams.
Right.
Field of
Dr.
Rocky 4.
Oh, Rocky 4, huh?
Yeah.
Dr. Kotari?
Chuck the India.
Shakti India. All are very motivational, inspiring. And that's the reason why you people have come to that stage. I think our delegates will get the real worth of what is our faculty. And Tayu, your favorite movie?
Ponniyin Selvan, 1 and 2. I mean,
And
absolutely
yeah,
mind-blowing.
your movies?
Nayagan, Kamal.
Ah, Sahin, they're all Tamil movies. Okay, Sahin,
Yeah, I don't watch movies now, but previously I liked Dangal and very old movie, A Guide.
third
With,
movie?
with
Oh,
Guide. Deva.
Guide, it's very old movie.
Jayant?
DDLJ, sir, and all Shah Rukh Khan movies.
Okay, right now, now the time is up now, 9 o'clock. I think we had a wonderful time. This is the 39th webinar, international webinar in gastroenterology. We did not even stop during the COVID time. So I am very kind that ACG has endorsed all the webinar. We have delegates from all over the country. Right now, you can see people from Nepal and other countries also there. And I must thank my faculty, Dr. Tayu and Satya, for the wonderful deliberations in a nice discussion on a little difficult topic. In fact, master checkup to get the data is very difficult, and of course, cancer screening you can get it, but put it in a proper perspective is difficult. And ably moderated by Dr. Cash and Dr. Gras, and we had a great panel with the Dr. Kotare, Dr. Sahin, and Jain. They're all our ACG members. ACG doing a great job in India because of the lively academic the sessions, and I last 10 minutes we had something to know more about it, so that will inspire our delegates who are checking and listening to you from all over the world. So thank you very much for this wonderful